in
Thank you.
postprandial sugar control.
So thank you so much for those kind words of introducing me. And when this topic was given to me by Dr. Benshi, I was actually a little bit surprised. Why a very, very old topic? And that too a drug which was discovered in the 1980s. And then I soon realized, of course, there is a significance, there is a renewed interest in this topic, and that is one of the main reasons why there is a lot of participation also for this dedicated PPG symposium. Dr. Sunil Gupta couldn't make it because he left in the morning, and he was supposed to discuss on insulin. Of course, insulin is one of the most important weapons, and we were listening to Depmale, and it was a very fantastic lecture by Depmale on Voglibos, Acarbos, and of course, this is again on another molecule. And when he was asked on ripaglinide, he said that the next lecture is on ripaglinide. So thank you so much. So these are my disclosures, and I will start with the pretty girl. And this lady is having pre-diabetes. Assuming this lady is having pre-diabetes, I will start with the AGP report. And uh, of course, this is an ambulatory glucose profile. As evident, this looks like almost a normal one. And even when the glucose is between 70 and 180, so most of the time it is between 70 and 180. But still, very evident will be the post meal excursion. So after a meal, including after a snack, there is a pronounced glucose excursion. And that is there even in people with normal glucose tolerance. That is there much more evident in people with pre-diabetes. And these are the individual days in a AGP report. So moving on to an ambulatory glucose profile, this is the AGP. AGP classically means multiple days, minimum 14 days of reporting, and qualitative form, and look like a 24 hours model graph. And AGP report will have three components. I don't have the third component here, and two components are here. But here, when you move from the ordinary pre-diabetes to a classical uncontrolled type 2 diabetes, these excursions are much, much more pronounced. So you see that after every meal, there is a glucose excursion. And this is when you started discussing and measuring the glucose variability. So I was listening to whether acarbose need to be given once daily or twice daily or thrice daily, and what should be the dose, 25 or 50 or 100. Everything actually depends on what? Everything depends upon glucose monitoring only. So you get the answer for glucose monitoring. If the people cannot afford this, you go for the ordinary SMBD. So that is how you manage diabetes. And we are overexposed. We doctors are overexposed to small events, big events. So we are having multiple events every weekend. So all of these terminologies, all the glucose metrics, everything related to probably the basics of diabetes is known to everybody. So all of you are actually masters. But I am little bit skeptical. I think the chairpersons will also agree with me. More than 70% of those doctors who are really involved in diabetes practice, they may not be probably attending all these conferences. They are still, even today, they are busy with their practice. So that is the reason why we are not achieving our goals. Sir, agree with me. Yeah. That is the reason. And that is the reason why, look at the data. The data shows that PPG of 62.5% of the population with diabetes in the country, it is above 180. So we are not reaching the goal. So many a time we keep on telling that we are trying to reach the goal, but rather we are treating to failure. We are actually not treating to success. We are trying our level best, but those doctors who are really treating the patients, they are not actually getting the right message. And this is known to everyone. The basics of diabetes. In type 2 diabetes, the first phase of insulin secretion, it gets blunted, and over time the second phase of secretion, it is sustained until normal glycemia is restored. So this is known to everyone, and these are probably some of the early markers of type 2 diabetes progression. And the time which is spent in postprandial, because this is a PPG symposium, this is the event where we are discussing about the postprandial state. We are all in the postprandial state. So how long do you actually are in this postprandial state? What is the average duration? So conventionally you say it is almost 12 hours, but for many doctors like us, you and me, when we are practicing until late night and having a dinner at 10 o'clock or 11 o'clock. Many doctors I know, they are having food at 12 o'clock at night. So the postprandial, that period that is patient spending will be more than even 16 hours a day spent in postprandial. So it is actually very serious. And that is one of the reasons why we people are having a lesser, 10 years less lifespan. And this is also an eye opener. So every time you will publish a data, and every time you realize that we are not at goal, the fasting is not at goal, the postprandial is not at goal, the hemoglobin A1C is still at around 9%. So where are we actually making the mistake? We are actually attributing this to our carbohydrate intake, the Indian gut. Of course, Indian gut should be different and the food could be different. And if you are traveling from Gujarat to Kerala, again the food is going to be different, but the carb content may remain the same. And this is different from the Caucasian population. So this is of course a reality. But if you look at the data of a gliptin, or even for the oral GLP-1 such as Rybelsus, or for the GLP-1 receptor agonists at large, DP4 inhibitors such as sitagliptin, if you look at the subgroup, and if you do the analysis, the Asian population when compared to the Caucasian population, the benefits were significantly better. So the drugs, probably if you look at the data, it is better when compared to the Caucasian population. So what are the solutions? We have been discussing, we have been questioning, and we have been debating. So again, back to the same statement again and again. Rather than providing a prescription to the patients, either it is vildagliptin in combination with or a triple drug combination, the most important component in managing diabetes is not a prescription. It is advising the patients on structured glucose monitoring. Otherwise, how can you manage? So you don't know how to give, which drug to give. How will you manage? What is the fasting? What is the fasting on Monday versus on Saturday? What is the postprandial after breakfast? What is the postprandial after dinner? And you need to have the drugs, including medications, including injectables, with a less chance, less propensity to produce hyperglycemia. And very important, that should be budget friendly. That is one of the reasons why we are looking for the generics. We are eagerly looking forward for the biosimilars, because most of these newer drugs are very, very expensive. So more than 80% of the people cannot afford. And so this budget friendly is very, very important. It should be cost effective. It should be cost saving as well. And this is a algorithm. You know this algorithm is familiar to everyone. This is how you titrate the premix insulin, and this is how we all teach our doctors, our students. Look at the fasting, look at the pre-breakfast, look at the pre-dinner. But what which is missing, the piece which is missing in this puzzle, is you are not measuring the postprandial. You are not measuring 2 hours after the food, which is most important. That is missing in these algorithms. So we have to tell our colleagues. I know that all of you are speakers in your own cities, in your own forums. So when you are training or when you are empowering your doctors in your cities, please let them know that when you are having a structured glucose monitoring, it is very, very important that they should be measuring the postprandial as well. In our telemedicine system, which we started way back in 1997, we measure 2 hours after the food in all of the patients. But at those times, CGM was not available. So this is very important, because this postprandial is the component which is responsible for all these complications that we are worried about. We are worried about the retinopathy, nephropathy. We are worried about the oxidative stress. We are worried about the glucose variability, which can induce an endothelial injury, retinopathy, neuropathy, and even carotid intima media thickness, blood flow. And in the American Geriatric Society official journal in 2003, they published a paper. And that paper was on variability in the glucose, recurrent episodes of minor hypo, unrecognized by the patient, responsible for cognitive dysfunction in the elderly. So when you are giving a blind prescription without any monitoring, it can even induce cognitive dysfunction. It can even be a reason for dementia in the elderly. And some time back, we published this data on exploring and resolving the impact of food on PPG in a rice-eating population. And this is the Diabetes India group, exactly I believe 10 years ago, in 2015, when we came out with a consensus And Dr. Sadikot, the founder of our own Diabetes India, he was very active at those times, and I still remember when we published this paper together, a consensus statement on management of postprandial hyperglycemia in clinical practice in our country, which is so relevant even today. And this is of course a recap. This is old data which I am going to present now, but it is worth probably revising recap, because some of these we have been probably discussed for many years. Look at the postprandial hyper and CV mortality and morbidity. I would like to focus on this cancer mortality. So common, because many of our patients are also developing cancers. And when somebody is getting treated for cancer, it could be chemotherapy, including corticosteroids, very commonly used in cancer. But don't you think that management of glucose is neglected, completely neglected in the oncology departments? And the patient usually dies of not cancer, but they die of diabetes and its complications. And the hemoglobin A1C will be 14 or 15, and the only focus will be on chemotherapy. And even the family will completely forget about glucose monitoring. The moment they monitor, at least once they monitor, they realize, oh my goodness, the glucose is more than 400. That is the reason why this poor man is so tired. So you have to promote this in all the entities, not only in cancer, but also the comorbidities nowadays should include the cancer as well. Because in obesity also, when we are lecturing on anti-obesity drugs, we give prime importance not only for the directly related complications, direct hit of obesity, but also on related complications, especially more than 30 cancers, very difficult to treat cancers. And all of these, the PPG, all of these contributing to ASCVD, this data is also important. The PPG and the microvascular complications and the huge burden, and this probably you could have seen this slide minimum 1,000 times in the lectures. Yeah, when the A1C is gradually reaching 7, still the contribution from the PPG, the postprandial, is a huge contribution to the overall hemoglobin A1C. So that is again back to the algorithm for insulin titration. If you are using only that algorithm before the dinner and before the breakfast for titrating the dose of a premixed 30/70 insulin, how do you know that the postprandial is controlled? You will never get to know that. So you should definitely measure, not once in a while, every week you have to have a structured measurement of postprandial as well. You can modify based on the glucose monitoring, you can modify the diet, and you have several drugs to choose from. So that is something which is so lucky, but at the same time, our subspecialty doctors are so much concerned, they are almost mad now. The cardiology, the neurology, the nephrology, looking at the long list of drugs in diabetes. Nobody can remember this. The long list of injectables, the long list of oral therapies. So many doctors are finding it extremely difficult to remember all these names of all these drugs. We had only 3 of our drugs in the past. And you have more than 6 to 7 oral and injectables for addressing the postprandial. And when you are having all these medicines, including the injectables such as insulin, the GLP-1, when you consider the expensive drugs, that is a barrier. And when you consider those drugs which have the less propensity to produce hypo with multiple other benefits, then you are worried about the GI side effects, you are worried about the genitourinary infections. Of course, pancreatitis is almost eliminated, because even a recent study has shown that GLP-1 use doesn't increase any risk of pancreatitis. It's without a GLP-1, there is more of pancreatitis. So that worry is not there, but still the concern is with multiple other factors. But we are here to discuss about some older therapies. We discussed about acarbose, and I am now here with repaglinide. I think we have forgotten this drug. How many of you are using repaglinide actively in your practice? That is so more than 10 people. Yeah, 10 doctors are there. Even I am not using that actively. So we have probably forgotten it. It is one of the best drugs. We have been, all of us were, WI is using. So earlier I used to use it, but the pharma, they are not promoting this drug now. But we as doctors know that this is extremely useful and should never be neglected and should never be ignored. It is a old drug. USFDA approval was in 1997 or so. It was discovered in the late 1980s. And look at the specifics. Some unique properties are there which are so different from glimepiride or glibenclamide. So different from the other class of sulfonylureas. And these factors reminds me of the newly getting launched inhaled insulin, Afrisa. Lot of similarities are there with Afrisa. Of course, Afrisa is going to be very, very expensive, prohibitively expensive, but this is affordable. Very fast acting with a very, very short duration of action. So if you look at the duration of action, see, it is very short duration of action, unlike the classical sulfonylureas. And then primarily it is addressing the postprandial with a very, very low risk. And this is another factor, because I was listening to the questions on acarbose a while ago. So if you look at the excretion metabolism, it is through the liver, and hence it can be safely used in the presence of renal impairment. And it stimulates similar to sulfonylureas. It is acting on the sulfonylurea receptor. So this is the pancreatic beta cell. You have the GLUT2, the glucose is getting transported, and then you have the ATP. So there is the ATP sensitive potassium channel. This is SU receptor. So this is binding on a different site in the same sulfonylurea 1 receptor. 2 is in the myocardium. So it is very specific. So it is safe and the closure of the ATP dependent potassium channels, and you have the opening up of the calcium channels, and this is exocytosis of the insulin granules. Very classical, and we have been discussing about this for quite some time. But the difference between a sulfonylurea and a ripaglinide is this is glucose dependent. So how do you define glucose dependent? Very easy. So when there is high glucose, what happens? There is more of ATP production, and the potassium channels will stay closed for longer, and that means more insulin will be released. So more insulin will be released when there is high glucose, whereas in contrast, when there is low glucose or relatively low glucose, when there is a hypoglycemia, there is less of energy production, and the potassium channels will stay open, and then there is a limit to the insulin secretion. There is a limit to the secretion of insulin. So this is a classical description. Fast on, fast off. That is how I compare this with inhaled insulin. Very rapid action. It goes in and goes out very fast with a duration of action of only 1 to 2 hours, and it maintains the pancreatic beta cell function. So that is very attractive. So whenever we speak about sulfonylureas, we are worried about exhaustion of the beta cells. That doesn't happen because it is of a shorter action. It doesn't result in exhaustion of the beta cells, and it is also addressing the blunting of the first phase of insulin, which is lost classically in type 2 diabetes, even in the earlier phases, and there is no disruption of the pulsatile secretion of insulin. So very close to the heart. So whenever we are discussing data on newer drugs, we discuss about CVOT. All the doctors are very much concerned about the CV safety. I know that sulfonylureas may not be that CV safe, except maybe one. And this is a very old slide, and this is ripaglinide. So I will be finishing very soon. I think, okay. What is it? Yeah.
Please continue.
Because the Sulgupta is not there. Yeah. And this is ripaglinide. And if you look at the forestry plot, it is very, very CV safe. And there is one more drug among the sulfonylureas which appears to be different from the others, and that is glycoside, which we are all familiar with. And this is the composite of CV outcomes. Again, significantly better for ripaglinide, and this is what we discussed at the beginning. And this is comparing with glimepiride. Okay. So this is comparing with glimepiride. This drug is excreted via the metabolized in the liver, and hence even for people who are on dialysis, of course we do give only insulins, but even in advanced stages of renal disease, ripaglinide can be given without any dose modifications. That is why I said in the beginning, we are forgetting this molecule. And with respect to A1C reduction also, it is almost equivalent to other sulfonylureas, 0.5 to 1.5%. This is from the recent ADA guidelines, and the weight gain is more common with sulfonylureas but less with ripaglinide. Remember, very important, you have glucose monitoring, and these are some of the added advantages. PPG levels are significantly addressed, and a lot of studies showing improvements in the CV risk factors, including lowering of the lipoprotein A levels, PI1 homocysteine levels, and then reducing the other CV risk factors. And when you compare the adverse events and the tolerability, there is a substantial low risk of hypoglycemia with RIPA when compared to sulfonylurea. And 2 or 3 studies in the next 2 minutes, and this is RIPA against glimepiride, and this is Ergo F trial. And 3 times of ripaglinide, small doses at the beginning, 0.25, compared against 0.5 milligrams of glimepiride, and this is for 2 weeks. And both ripa and the glimi is escalated to 0.511 milligram, and these are the results. There is a robust reduction not only of A1C, but also there is a reduction in the hypoglycemia with the use of ripa when compared to glimepiride. And in another study, this is two group. One group, 56 patients on basal insulin glargine, and the other group, basal insulin and ripa added on to basal insulin. And look at the glucose metrics, and this looks very, very impressive for fasting, for postprandial, and for hemoglobin A1C. There is a substantial reduction when you are combining basal insulin with ripaglinide. And that too, if you look at the total daily dose of insulin, almost 50% reduction in the total daily dose of insulin when you are combining with ripaglinide. And for hyperglycemia, numerically it is more important in the control group when compared to the insulin and ripaglinide group. So insulin only group, more hypo. When you are combining with ripaglinide, of course you are reducing the dose of insulin, better hemoglobin A1C, and less of hypo. What about the elderly population? In the elderly population also there are studies, and this is in 57 elderly lean patients in type 2 diabetes, and this is the data. The glycated hemoglobin levels, and this is the glycated albumin levels and glycated albumin by HbA1c ratio. It is better, and also there is improvement when compared to sulfonylurea in the glucose variability. So one more, and this is about combination, and then I will be stopping. Ripaglinide in combination with voglibose. It is available, and it is cost effective as well, but less probably used, and this is complementary. This is supplementing with each other because of the different mechanisms of action, and alpha glucosidase inhibition modifies the rapid insulin release by ripaglinide, and there are no significant drug interactions between the two. And better A1C reduction with the combination when compared to only ripaglinide. And if you look at the PPG reduction, so you know that these two drugs are better for PPG reduction. So if you focus only on PPG, there is a 2 times better reduction in the PPG, with more than 50% patients in the combined arm able to reduce hemoglobin A1C by more than 1%. So more than 1% reduction in more than 51% in the combination. So in summary, I have discussed about ripaglinide. I have briefly discussed about the combination with a plethora of benefits. But the take home point will be, don't ignore it, and one meal, one dose. So when you are having an extra meal, you can have an extra dose. So if you don't have a meal, you can skip the dose of this drug. So this is my concluding remark. So in modern day diabetes care, we often discuss only about the newer therapies and technologies. But time tested drugs such as acarbose, time tested drugs like ripaglinide shouldn't be forgotten, and these are affordable. They are still very effective because diabetes remains the same, and these are some of the remedies which are proven through decades of real world success. So this is one invitation to all of you. So we are organizing the RSS Day this year in Kochi in Kerala. Please get registered. It is after 14 years, all of you are going to be in the beautiful city of Kochi. So thank you again for your patient listening. Thank you.
Thank you. Thank you.